Good morning. It's April the 2nd. I'm one day late because of the Easter holidays. Strictly speaking, the university's on holiday today as well on the Tuesday the 2nd. But I don't like letting these things run away with me. So here I am in front of the machine. And what a bumper crop I had this week. I had loads of stuff from the Middle East. Thank you very much, ladies, over there in Saudi Arabia. Loads of stuff from the Middle East. All with interesting comments. But I'm going to start this week by talking about Pauline's comments. And Pauline's got in there, and Pauline, don't put yourself down. You keep saying that. You're more interested in the psychological than the technical aspects. But don't box yourself in. You haven't said anything wrong technically, so why would you? Everything's fine. But anyway, she's focused. Pauline zoomed right in on some of the more personal aspects, some of the more interpersonal aspects, and you can really see the depth of experience here, Pauline. Frankly speaking, you can. And I asked the question in the lesson. Why is it that people don't remember how well is communication conducted in the acute phase of heart disease or heart attack, MI? Pauline goes right to the key issue, really, that a lot's going on. Things are happening. And things are happening in unusual times of day. You were getting ready for work, and now you're in the hospital, and things are happening all around you, and people are struggling to meet deadlines. So perhaps they aren't really concentrating as much as they would do in a normal set of circumstances on explaining everything to you, stage by stage, because they are conscious that the clock is ticking, and in their head, I suppose, they are prioritising, and they're thinking, well, we can always explain this later. What we need to do now is save muscle. So perhaps in the early stages, at least, there's not an awful lot given over to the question of explaining things in full, and then there's the question. Are you ready to receive the message that is being given to you? Even if somebody is going through a comprehensive explanation, there you are. You're scared. You're maybe tired. You're in pain or stuffed up to the eyeballs with opiates. It's not exactly the best environment in which you're going to take information in. You're likely to be creating your own explanations in your head, and so Pauline extrapolates from her experience of working in general practice, and what she says is that sometimes it's a better idea if you get somebody coming in with a new diagnosis on them, something like diabetes. Then maybe the best strategy is to, as she puts it, drip feed information. Give small amounts of information often. Check whether or not they're taking up the message. Smashing. And as Pauline says, always back it up with written material, because one thing's for sure, they're gonna remember questions they would have liked to have asked when they get home. And now there's nobody around that they can ask. Whereas if they've got a leaflet in their hand and you follow the course of the leaflet, then this might be enough to remind them. Yeah, okay, smashing. Little bit trickier in the acute phase, I would have thought. The person's not calm. They're not set down. Things are happening all around that's distracting them. Which again underlines even more so the importance of the written backup material. And yes, Pauline in her correspondence with me this week was bringing out conclusions that she has picked up from general practice, and she's applying them to the post-infarct, post-cardiac rehabilitation patients. And I've got to tell you that my experience of backup in the Liverpool area, backup from the general practitioners is wholly good. Is wholly good. Number one, absolutely watertight blood investigations, blood and other investigations. Absolutely watertight follow-up. 6 months with the practice nurse. I'm due to go any minute now back to see the practice nurse. No feeling whatsoever that I'm under pressure or I'm being hurried up. Everything is gone through in fine detail. My experience is wholly good. The next thing that Pauline wants to pick up on is, and what she says is that she says in her correspondence to me that the two nurses that I interview, both ex-students by the way, both senior sisters over in a local hospital, and both ex-students of mine, and top class, great in class. I had absolute confidence that they were great in practice too. But Pauline says that these two nurses didn't mention the question of depression, and depression is, well, I'm not sure you'd see that. I'm not sure you'd see the depression, frank depression, in the first couple of days following an infarct. I think again there's too much happening. There's too much to distract you really. But it's well reported. Depression following infarct is well reported. And when I had my infarct, for instance, I kept on thinking, okay, depression is on the way. Just bear it in mind, and when it happens, don't take it too seriously because it's kind of in the script. And to be honest with you, I never got depressed at all. In fact, my thinking throughout the entire process, because I felt so well, my thinking throughout the entire process was to think, I've got 3 months off now. If I've got 3 months feeling like this, I'm going to really have a good time. And I did. Didn't feel ill at all. Which makes you wonder, doesn't it? Which makes you wonder that there's another aspect to cardiac psychological rehabilitation, and it's this: a lot of people are in denial, and sometimes I wonder whether that didn't defend me from a bad bout of depression. That good old denial sort of makes the whole thing a bit more comfortable, maybe. And you are entitled to wonder whether the idea about being frank with patients and the idea of giving them the information that they need doesn't in some way undermine the psychological defense mechanism that is called denial. Because as Pauline says, here is a person who's had a near-death experience. That's bound to be psychologically challenging, and if it isn't, well, why isn't it? Yes, Pauline, yes. It's a fine line to walk between the psychologically taking your patient's problems seriously, and they are serious problems, and therefore psychologically you should be on guard and careful with them. And on the other hand, try and break the atmosphere, try and lighten the mood. It's not an automatic death sentence. Paramedics do this really well. You are quite right. They are first class at, I don't know how it is that they do it even, but they have a sort of knack of detoxifying a situation and brightening it up to some extent before they hand over. Yeah, well done, Pauline. Well done. Next we have Rachel. And what Rachel wants to talk about is we're going back to PCI with Rachel, and that she points out absolutely on the discussion board there that something I've observed in other contexts. Cardiology is becoming radiology, isn't it? That what PCI has done is it's converted cardiac physicians skilled in the administration of cardiac medication to a branch of radiology, that is to say, put your leather gown on, put your thyroid protectant scarf on, and poke tubes up arteries until you unblock what's blocked. You know, in vascular surgery, for instance, this is now well established. You know, that radiologists have taken over. In neurologists, you know, my understanding is that it's not unknown for brain surgeons to retrain as radiologists. Why? Because they are now operating inside people's brains using coils and catheters, which doesn't necessitate taking bits of cranium off the way things were in the past. So we're watching, you know, not only are we watching a therapy in transition here, we are also watching a medical speciality in transition in some respects. Rachel points out that what this has all meant, and I addressed this in one of the lessons with the sister from the coronary care unit at the Liverpool Heart and Chest Hospital. Staying in coronary care is now down to 24 hours, you know, and given everything that we were talking about with Pauline, you know, what has this done to nursing care? You know, has this meant that nursing care in the coronary care setting is less important because you're just getting people from theatre, waiting until they settle down and passing them on to the ward? There's no time to get to know anyone. There's no time to get to know anybody's family. No sooner have you've learned their name than they're off again. I mean, I'm saying all this, but I still think it's an improvement. Whatever it's done to the nursing care in the coronary care unit, I still think it's an improvement, you know. And you're out after 3 days. I mean, there was a time, and I remember this as a student nurse. You were kept on bed rest for longer than now you are kept in hospital in total. See what I mean by that? You were kept on bed rest, not allowed even to go to the toilet, for longer than now you're kept in hospital as a whole. That's how far things have changed. Yes, the radial approach, very comfortable. You can leave the person's wrists out of the bedclothes. You can keep an eye on what's happening. If they start to bleed from the radial artery, you can see it quickly. It's not subject to bend so much as your legs. You know, you don't have to keep people flat. You know, if there's a complication with this artery, it's not as serious as a complication with the artery going down into your leg. You know, the last thing you want post-infarct is an ischemic episode in the person's leg. Whereas for you at the radial artery, you've got 2 arteries that go into your hand. So there's always a backup. Yes, absolutely, absolutely. And lastly, we've got Rose, who tells me that according to the British Heart Foundation, now over 90% of patients within the UK will get primary PCI. You could say, about time, you know, it's about time everybody else had gone over to this system before the National Health Service. You could also say, what an achievement that in 5 years, 6 years, the whole country has gone over to a brand new form of treatment. This is some achievement for the National Health Service, all right. Okay, one last thing to say. Shirley has from the Middle East again. See, the Middle East has done me proud this week. Shirley's offered me the first draft. I'm not going to look at it today, Shirley, because officially I'm still on holiday. But I will have a look at it, and I will offer you my sincere and honest comments over the next couple of days. So bye bye everyone. Good to see you, and happy Easter.